Everybody. Welcome to the England and Wales ITP Patient Support Group meeting for June 2022. My name is Mervyn Morgan. I'm from the ITP Support Association, and it gives me great pleasure to actually welcome expert today, Dr. Alice Hart from Imperial College Healthcare Trust in London. Welcome, Alice. Thank you for joining us. No problem. I'm just looking around the room. We've got another one of our patient mentors, Karen Smith, here as well. Welcome, Karen. And just joining the room is Colin Williams, one of our the association's trustees. Welcome, Colin. Okay. Has anyone got any questions they would like to kick off? Come on, you must all be, because the first one of these we've had for a couple of months. So any questions, anyone? Or can I just start? Was that a hand up I just saw then? No? Yeah, Fran, you got a question? Are you muted, Fran? The little microphone button at the bottom of your screen. You got it? That's it.
Is that okay?
That's fine. I can hear you now.
Lovely. I'm on bromiplastin injections weekly, and they're not working as well as my specialist hoped. They're not keeping my platelets high enough. What's the alternative? Can you just keep taking this stuff, or are there other options?
There's definitely other options. Yeah, there's often other things we can try. The first thing would be to check that you're on the right dose and that you're on the taking it weekly and you're on the maximum dose for your weight.
Yeah.
So it's usually 10 micrograms per kilo. So if you weigh 70 kilos, you should be on about 700.
Yeah. Well, I'm quite heavy, so I suppose I am then, yes. I'm taking a 1.3.
Oh, mils.
Yeah.
Yeah. I don't know what that is in micrograms, actually.
No.
Okay. Have you spoken to your specialist? Because obviously,
yes, I have my bloods done at my GP's every week, and then she rings me the same day later when she gets the results. And we got it up lovely all through last summer. I was climbing a bit, and it was steady, and then all of a sudden it plummeted, and she upped my dose and upped my dose and upped my dose. And my last bloods, one was 18. And then the next week it was 32. So she said it's, she'd like it a little higher.
Yeah, yeah. And is that the first treatment that you've tried other than steroids?
Yes.
Yeah.
I had 2 infusions last year, but this is the first and only drug I've had for it. Yeah.
Okay, so you didn't even have steroids first, presumably?
Oh, I take steroids anyway because of other conditions.
Oh, okay.
So I did have a big blast of prednisolone. I had 30 a day weaning down.
Yeah.
Now I'm on 5 a day ongoing.
Yeah. Okay. Okay. Well, often we try the other thrombopertine receptor agonist, which is L-Trombopag, which is a tablet.
Right.
And there'll probably be people on the call who've had experience of that as well. Some people can respond to it even if they haven't responded to the other one. What's important with that one is there's some dietary things you have to be a little bit careful of.
But something to do with calcium, isn't it?
Yeah, yeah. But most people find a way to work around it, depending what time of day you take it, or altering your diet a little bit, that sort of thing. So it can be a good option. The other thing is Rituximab, which I know during COVID we were avoiding, but actually the thing that it's a problem for is making an antibody response to a COVID vaccine. So if you've had your vaccinations, then actually Rituximab's not so much of a problem. So I would think those are probably 2 next reasonable options
if
for
the
you.
figures won't
Yeah,
improve.
yeah, exactly. Are you looked after at a big hospital or a?
Yes, reasonably so. I'm in South Wales, so it's the Royal Gwent Hospital. And there's a daycare unit that the hematologists run on a Monday. They're there all day.
Yeah.
If you have a problem, you can go down and they. Yeah. But I tend to be looked after. My daughter does the injection for me. So
the thing that's frustrating about ITP is we can't tell who's going to respond to which treatments. So we just often have to try something, and if it hasn't worked or the response is lost, then go on to the next thing.
That's right.
So I think that can be a bit frustrating whilst you're kind of waiting to see what happens. But there are always options.
Good, thank you.
Yeah, that is one of the things, isn't it, with this condition, that what works for one patient doesn't work for another patient. And, you know, that actually come up in the NICE meeting today about the variations around. And, you know, you need a lot of tools in your toolbox as a haematologist to actually cope with this. Now, any other questions before I move on that? I've got one now from Sue Wheel, and this is interesting. There's people on romiplostin here.
Yeah.
I know Diane is, right? And Diane, have you ever been abroad? Or you have to take the injections? You're muted, Diane. God, I wish I had £1 for every time I said that over the last 2 years. Yeah.
Right, I said it's always me that's not unmuted.
No, it wasn't today. It wasn't. Yeah. It wasn't the first. No.
I have been abroad, actually. I went to America.
Yeah, and
albeit for 5 days. So what I've found.
Well, the question is, Sue, do you want me to read your question out, or? You're muted. That's it.
Yeah. I've been taking romiplostin now for just over a year, and yet starting to travel away from home a bit more. So it was just really any advice, or you know, keeping it cold and all those things, you know, practically. And I just wondered if people are finding travel easy or not. I was at hospital having my injection for a lot of weeks. I've only been doing it myself a few months. So maybe I just need to get my confidence up to go.
Yeah, I think it depends how long you're planning on going, really.
Only about 12 days.
Right, okay. I've not been for that long, admittedly. I mean, I went for 5 days to the States, and I just manipulated my injection days around. You know, it's a case of planning, really.
That's why I started to think that the days are not going to fall well. So maybe instead of 7 days, do 8 days, and gradually get it to a different part of the week and things.
Well, I think
probably only have to take 2 with you, wouldn't you? Even if worst case scenario, you only have to take 2. I think we usually say to people to have it in a cool bag for the traveling, and then put it in the fridge when you get there. So don't panic if you know it's.
It's not going to be too bad.
No, a cool bag is enough.
And then just me personally curious, I've been doing the injections in the morning. Do other people find another time of the day better? Because I still get side effects for 24, 36 hours that can vary week to week. I just wondered if there are people here saying, oh no, I always take it at, I don't know, 9 o'clock at night and that's my perfect time. I'm just curious.
Karen, you had your hand up?
I only had my hand up on a practical note that I was pre-COVID. I was traveling abroad, and I got my consultant to write a letter saying that I had ITP and I needed to carry this injection with me because it contains a needle, and if it gets X-rayed on the way into anywhere, then they might hold you up. But if you've got a letter from your consultant, it'll be fine. And I've travelled in this country for long journeys, like from here to Suffolk, when it was gruesomely hot last summer, and I kept my romiplostin in a cool bag.
Right.
And I put one ice pack in the cool bag, but separated it well from the romiplostin by 3 or 4 layers of bubble wrap, so the romiplostin didn't come into contact with the too much, you know, icy cold directly, and it was absolutely fine. I had my bloods done afterwards, and they were still the same. So I gather, you know, the injection must have worked just the same.
Thank you.
And Did you have to take a sharps box, Karen, with you?
Yes, I've got a sharps box, a little travel sharps box. It's really dinky. My haematology unit gave me one.
Oh, right. Okay.
And I've had the same one for ages, because what I do is I very carefully tip the contents out into my big sharps box.
When you get back.
When it needs emptying. Yeah.
Okay. Okay. Does that answer your question, Sue?
Yeah, thank you.
No problem. Right. Bonnie, you had your hand up?
Yeah, it was just for Sue, really. I travelled loads when I was on Nplate, and you can get really tiny ice packs that are therefore less than the liquid that you're allowed to take through, and a little cool box. And I always, the same as you, Karen, always had a letter from my clinician just saying this person needs to carry this. But I also used to phone the airline before I left and said, I'm traveling with needles. What is your policy? What do you do? Some say, don't worry about it. It's fine. Others say, we're going to write that on your actual boarding ticket so that you don't get stopped as you go through. So I did everything because I was so kind of worried about it. And I just had a little tiny, you know, the tiny sandwich cool boxes. And I just had like I just put everything together so that I always brought that out first. And I always said, there's needles in here. So they used to always take it and go fine. And sometimes they swabbed it and did all that. But on the whole, if I brought it out and said there's needles in here and put it at the front, they were absolutely fine. And only a couple of times did they want to get the little pot out and look at the powder. Other than that, they hardly touched it. But definitely a letter. I went to India with it, and I thought that was going to be a nightmare. So I wouldn't change all your days. I would just say, this is what your life is. This is the day I take my injection. And basically that I have to have this little pack and a letter, and you just get really used to it. So don't panic, because people are actually unbelievably chilled about it. I thought they'd be like, what are you doing carrying needles to India or whatever? And actually the minute you declare it, they're like, yeah, fine. And they almost don't care. So I would say prioritize your medical regime and just do the practicalities, phone the airline, have a little box, get a tiny ice pack. And also on the plane, they'll put it in the fridge for you. So if you give it to them, to the air hostess, and say, can you please put this in the fridge? It's got medication that must get kept cool. They have no problem about it. The problem you have is remembering to pick it up at the end of the flight. And you're like, oh my God, I've just left it. So it's amazing. People are amazing. So I would say be confident in it and just let everyone know what you're doing.
Thank you.
Cool. It's a bit nice to be talking about traveling again after all this time.
Yeah.
Yeah. Okay. Leslie, are your hands up?
Yeah, I recently also traveled to America with a different injectable, with belimumab injectables, which are really quite big syringes. And unfortunately, Bonnie, I had a different experience when asking the flight attendants to put it in the fridge. They said on British Airways, they're not allowed to take anything from passengers to put it in the fridge. And that was 4 different BA, 2 BA flights, 2 American flights.
Is that a COVID thing?
I don't know, but they all said no. So I had a cool bag with the mini, the same thing as you, with the mini ice packs, but the flight attendant said they're not allowed to take anything. It might be COVID.
Yeah, because I did all my travel before COVID, so maybe that's a bit different. But definitely check in with the airline.
Yeah.
The other thing is, romiplostim has, I think, a protocol now that you can keep it at room temperature for a week without being refrigerated. So it doesn't matter if it's not kept absolutely at fridge temperature the whole time.
Okay, thank you very much, Leslie. Right, anyone else got a question? Karen Davis, did you have your hand up? Yeah, Karen?
Yes, please. So I'm brand new to the group, so it's nice to be with you and to be part of it. I've had ITP since about 2007, and it's come and gone over the years. So I've gone into remission sort of on and off, and I've generally been treated with, you know, I've had IVIG, but steroids have been good for me. I was in remission, and then it actually came back at the beginning of COVID, and then the steroids worked for a bit and then didn't work. So I'm on romiplostim now, but I do tend to go really high. So my platelets have gone up to 900 and something, but then within a fortnight they've been back down to 4, and then they've gone up and down, really up and down. And I just wondered if that's common, and if it's likely to settle down at all.
Tricky, isn't it? I don't know if anyone else has had the same problem, but it's definitely something we do see. I think about a third of people have these very fluctuating counts, and it's perhaps a little bit more so with romiplostim than L-Trombopag. Some people it does settle down. It's usually worst in the first month or two, and then it settles down. I think it's also difficult if it's gone very high, because then people get worried. You know, people see a scary platelet count, and therefore maybe react and drop the dose. So you kind of end up seesawing a bit, which can be quite tricky. What dose have you ended up on now?
Well, they've been quite low. So, I mean, at the beginning of COVID, I was on 55 milligrams, and that worked and worked and worked quite well. But then it sort of, and then I think the dose went up a bit, but then actually things stabilized. So I came off romiplostim for about 6 months, from last September to March just now. And then this time they've been really more, much more of a seesaw situation. So the highest dose I think I had was, I mean, it wasn't as high as the one I was hearing about earlier on just now, perhaps 200 or something, or 210. And then that's it gets really high. And at the moment, 120 last week. But they can go from sort of 600 on the Monday to 76 on the Friday. And then I go and do a cross-country event because I think they're okay, because I'm a coach and I do quite a lot of horse stuff, which obviously can be a bit hazardous. And so I did this on the Sunday, but then they dropped to, I think it was 7 on the Monday. So, I mean, it's all a bit sort of frightening, really. Being around the horses is an everyday thing. So when I've only got such low counts as, 1s, 2s and 4s, I just, that's worrying.
When they weren't fluctuating, were you on any steroids at the same time?
I was, yes. So I started off on steroids again in March. And at the moment I'm tapering off now. So I'm on sort of 10 really, 10 milligrams. In fact, 5.
Yeah. So it might be worth just seeing what happens once you've finished the steroids, because that can sometimes make things a bit more unpredictable. But I also think some people it doesn't stop, and then you just need to try something else, because it's not manageable, is it, for you or for your life, and it means you're coming up to hospital all the time, having your dose changed all the time. So I think if it doesn't settle when you're not on anything else, and that you've tried low constant doses, then I would just try something else. Yeah. The other thing we sometimes find is that the combination of a thrombopertine agonist plus rituximab can be really good. So some people have stable counts. They have rituximab and then go on romiplostim or something, have stable counts, and then they start to fluctuate, and that's as the rituximab wears off. Right. So that's just something to bear in mind. But I think probably I would try L-Trombopag first and see if you get a more stable response. But it's annoying, isn't it? It's hard work for you with it changing all the time.
And a bit of a worry, because I think, well, if I get a knock on the head from the horse, then, is that it, kind of thing.
The other thing we sometimes do is split it. So it is meant to be weekly, but occasionally for some people we give it twice a week or 3 times a week, a very low dose, so that you're not getting peaks and troughs. You're getting a little, kind of lower profile increase.
Okay. And how effective? Oh, sorry, carry on. Sorry.
No, I was just going to say, so that's another thing to think about.
Okay, thank you. And so the tranexamic acid, I forget the name of it just for briefly. How effective would that be if there was an incident and I'd had some of those tablets? How effective is that to help the blood to clot?
Well, what it does is it stabilizes a clot. So it doesn't increase the platelet count, it doesn't change anything, it just makes a clot that's forming stronger. So it's good if you have a nosebleed or for heavy periods, that sort of thing. But it probably wouldn't be enough if you'd actually been kicked by a horse.
Yeah. Okay.
It's definitely a useful kind of adjunct, but it wouldn't be enough, I would say, to keep you safe with a platelet count below 50.
Yeah, so 50 is really the cut-off for doing anything that's remotely hazardous.
Anything with head injury, we say 100 usually. Anything with a significant risk of head injury, we would say 100. But I mean, it's difficult, isn't it? So if I wouldn't say riding fast on horses, if where you're going to fall off, I would say 100. But and I don't know, being around horses when you know the horses and you can, you know, the ones that are more likely to kick out and that sort of thing is not as dangerous. So everything in life is a risk assessment. So you just have to know yourself, know the horses, and try and do the best you can. I don't know if anyone else thinks anything.
Yeah.
I know a few of the people on here have actually used,
Thank you very much,
used tranexamic acid in the past. Diane's shaking her head, and I'm sure Karen, have you used it as well?
I think I was forced to take a tablet once when I was in hospital.
Yeah,
with a low platelet count.
Yeah.
I only took the one-off dose because I got some steroids, and I don't. Luckily, I don't bleed so far.
Okay.
I think people.
I've been told that if I get blood blisters, I should take the tranny acid, but I don't, because I just don't like taking stuff. But they say if I get bad blood blisters, that's what I should be taking.
Yeah, that's right. Yeah.
Definitely can, and it's really safe. I mean, there's almost no side effects. The only thing we say you shouldn't use it for is if you've got blood in the urine, because if it forms a clot and you get a clot at the outlet of the bladder, you can stop urine coming out. So but that's not really a side effect. That's just something you need to be aware of. So really it's very safe and very, very, very useful. So anyone whose platelet count is low can take it for anything. We always say take it and then ask us after, rather than you know, be afraid to take it.
Okay, now Bonnie and Diana got their hands up. Diane, is yours about this question, or is it a new question?
Well, I was just going to say, just sort of in regard of a few comments there. I mean, I carry tranexamic acid with me all the time in my bag and in the car because I find it invaluable, because I get a lot of mucal bleeds. But just going back to the bit about injecting, I mean, I don't know if anybody else finds this, but I find that my injections are more, what's the word, tolerable. If I take the romiplastin out of the fridge probably a couple of hours before I use it, because it's not freezing cold then when I'm injecting it, and it stops the stinging. So, you know, I don't know if anybody else finds that, but also somebody else mentioned, you know, is there a better time to take the injection during the day? And I think really the key thing is to do it, you know, when you're relaxed, not when you're under pressure. You know, so if that means, I mean, for me, I end up, you know, take the dog for a walk and go and sit in the bathroom with a cup of coffee in the morning and get it out the way then. But for other people, it might work differently. But I think, you know, the more relaxed you are, it's a bit like having bloods done, isn't it? You know, the blood doesn't come so freely when you're all stressed out. You know, you kind of dehydrate, don't you?
That's true.
And there's no harm in trying different things. There's no harm in trying for a couple of weeks, taking it in the evening and see if that's better for you.
Yeah, but I mean, I find that I know when my platelets are dropping because I get a lot of nausea. You know, I think the longer that you have ITP, the more you get, well, certainly I do, perhaps everybody else doesn't, but, you know, the more that you're in tune with your own body, the more you pick up the days when it's safe to do some things and it's not safe to do others, you know, because, I mean, for me, at my worst, my dog's only got to put his paws on my lap and I'm bruised, you know, or maybe somebody knocks a shopping bag into my leg and I'm bruised. I mean, you know, but you just kind of instinctively know when you're not so great. And for me, I try and scale everything back a bit and just think, right, give in to this, you know, just take a day out and have a quiet day and do a few jobs at home or whatever. But it's not always possible for all of us to do that, admittedly.
Okay, thanks, Diane. Bonnie?
Mine's a question for Alice, if that's okay.
Yeah.
So I'm a bit of a researcher, and I've researched everything from kale to vitamins to minerals to everything. But now I'm heavily into the idea of ITB being a secondary diagnosis to something else that might be going on. And so there's an article about iron deficiency with or without anemia, and the impact that can have, that sometimes people are diagnosed with ITP, but actually it's an iron deficiency that is kind of creating difficulty in the bone marrow, difficulty with platelet production, and etc., etc. So I've been struggling a lot with iron, and I had an iron infusion 8 months ago. It changed my whole life. I thought my fatigue and my exhaustion and my quality of life was as a result of my platelet count, because it was always below 30. And then I fought for an iron infusion, finally got one, and I realised it wasn't my platelets that was killing me gently. It was the fact I had literally, it's my ferritin, not my hemoglobin. So I'm an iron deficiency person without anemia. Completely changed my life. My platelets shot through the roof, and I've never had such a high platelet count. I felt amazing. And then over the last 8 months, in December, I was great. And then over the last 4 months, I've gone down and down and down. I'm back down to 19 with ferritin. I am on L-Trombopag, so I appreciate that's an iron chelator, so I know that. I don't eat loads of meat, but I'm losing a lot of that stored iron. And so I've started looking at the research, and there's a study in 2018, and it says we need to study this more. But it's just made me start thinking about, that's interesting, around whether or not ITP is my primary diagnosis, or is there something else going on, and the side effect is thrombocytopenia. And I just wondered what your thoughts were on that, and you know, how consultants are kind of thinking about that yet, or is it something that's still being thought about, or that sort of, what climate are we in with that, maybe?
That's really interesting that you brought that up. That's something that we started doing a lot more recently, checking everyone that comes to the clinic, we check their iron.
That's really interesting.
And if it's low, the first thing is to try oral supplements, and if people don't get on with them, then we would give them IV iron.
And what do you call low?
Well, it's a bit tricky, isn't it? So we would, I mean, obviously if the hemoglobin's low, that's obvious and it's straightforward. Yes. But we are very happy to give people iron supplements just on a low ferritin.
Yeah.
I think in our hospital, the bottom of the normal range is 20 or 30.
Yeah.
Which I think is quite low.
Yeah,
so
I do.
Probably be very happy to suggest supplements or IV iron if the ferritin's below 50.
Yeah. And have you found any correlation between people you've given iron supplementation or infusions and their iron or their ferritin's gone up and their platelets have gone up?
I haven't heard that. People feel better.
Oh God, yeah, absolutely.
Feel better, but I don't know that anyone's platelet count has shot up like you said. But I think it is also, it's really interesting that it's L-Trombopag, because that is definitely one of the chemical effects that it has to kind of take iron out the body. So I think it's certainly something that everyone on L-Trombopag we need to be a bit more aware of, especially as people are eating less meat.
Yeah. And what are your thoughts about ITP being a secondary kind of diagnosis, and actually sometimes we find out there's something else that is the primary issue?
Yeah, I mean, I think there's lots that we look for when people first present. We always check for lupus, rheumatoid arthritis, antiphospholipid syndrome, thyroid problems, viral infections, lots and lots of things. But then I think we may not find any of them at presentation, but it may be that later in life people develop other things.
And that's sort of what I feel. I feel like I got a thorough going over 5.5 years ago when I first got diagnosed, well, when they were looking for a diagnosis. And since then, it's like, we just know that I'm ITP and that's it. And I feel like something else could have manifested or brought to the surface in the meantime. And because we've done the H. pylori, the A's, the hepatitis B already, it feels like I'm now done. I'm an ITP person for the rest of my life. And I may well be. But I just think because other things are going on in my body, I feel like it is interesting to look at that and trying to resolve that, and not just kind of go, oh, well, that's just, you're just going to have low iron.
Yeah, I think it's often the kind of rheumatological things that come to light later. So you may not know at presentation, but people may end up having an inflammatory arthritis, joint pains or something like that, or end up having problems with their kidneys, and then actually it turns out that it's lupus, and it's just that the first presentation was a low platelet count. So I definitely think it's something that if you're feeling other symptoms, you should tell your specialist.
Yeah.
And we quite often check something called the ANA. I don't know if that checked. If that's positive, that can sometimes indicate that there's either another autoimmune disorder present, or that in the future one may develop. But until something presents itself, it's quite difficult to know. And actually, you wouldn't change anything for now anyway.
No.
Might be.
What made you decide to screen everyone for the iron? What made you change that practice?
Well, it's partly symptoms, really.
Yeah.
If people are tired, it's a really easily checked and easily remedied thing to make people feel better. And also, if you're having lots of bruises and a bit of an occasional nosebleed and heavy periods if you're a woman, you know, it's very, very easy to get low iron. And also because of the L-Thrombopac, so lots of different reasons.
And in terms of having an iron infusion with normal hemoglobin, people aren't worried about that. That's okay.
That's fine. Yeah, you just have the lowest dose.
Yeah. Okay. Brilliant. Thank you so much.
We've got loads of hands up, so I'll go to Kate next, then Colin, and then Diane. So Kate.
Hi everybody. I'm new to the group as well. I was only diagnosed in March, so it's all very, very new to me. So I'm just really interested, Bonnie, in hearing about the iron side of things. I'm on steroids at the moment, but I've also been seeing a kinesiologist, and my iron levels were really, really low. So I'm a vegetarian. I've been vegetarian for a long, long time. So I'm taking supplements, and so far, touch wood, everything's going in the right direction. Lots of other supplements as well, but that was a real big one that I was very, very, very low on. So I'm just really interested, really pleased that you brought that up. And it's been.
Have you noticed a change in your platelets having had better iron?
I mean, I presented at a hospital in March, and I hadn't heard of ITP. I just got the blood blisters, and that was 24 hours. I was in 10 days in hospital with platelets no more than 2 for over a 10-day period. So they're gradually reducing my steroids. I'm on 7.5 now. I'm hoping it's going to be reduced again. And just taking the supplements the last 3 or 4 weeks. So they're stabilising my platelets at the moment. So
that's interesting.
Really good.
Do you think there's a correlation between kind of your platelets stabilising and you being supplementing with iron?
I mean, iron was one of them. There was quite a few others as well. Right. I think basically my immune system was pretty rubbish. I think it's more that iron is a big one for me anyway, being vegetarian for such a long time. But I think I'm just trying to take better care of myself. I've gone gluten and dairy free for a little while to see, see how that is. Yeah. So, but the kinesiologist.
And were you vitamin D deficient as well?
Yeah.
Yeah, same here. I mean, this is a very similar story, isn't it? It's a very similar story.
Yeah.
We've had this lots of times over the last couple of years of doing these. Colin,
I think the question of iron is actually a very interesting one, which has been raised by Bonnie, and particularly because I'm in fact the direct opposite position, in as much as I suffer, in addition to my ITP, from genetic hemochromatosis, which is in fact an excess iron in the body, and I therefore constantly undergo venisections to get rid of it. And as a result of having both of these blood conditions, I've obviously spoken to many medics about whether there is an association between ITP and Epithet or deficiency in iron, and there seems to be no consensus at all amongst the medics on the subject. Some think there is an association, some think there is not, but also what seems to have occurred as well is that consequent upon the iron situation, it does affect the thyroid, and therefore I also, as a result of that, suffer from hypothyroidism. So I would be interested to know what Alice's view is, whether there is an association. I think correlation is far too strong a word, but I think I would like to know from Alice whether she thinks there's an association between ITP and in fact the blood conditions and the amount of iron within it.
So I think probably it's more likely that there's a link between hypothyroidism and ITP, because they're both kind of immune dysregulation, autoimmune disorders than with the hemochromatosis. Hemochromatosis is just a genetic switch.
Right.
And there are many people that have hemochromatosis without ITP. I suspect it's bad luck, but I don't know for sure. Occasionally we see the opposite thing that we've been discussing as well. So somebody gets referred to us with a high platelet count and it turns out they have low iron. We don't know the reason for that, but that's a physiological response to having a low iron, is that your body makes more platelets. Maybe because if you bled, you'd have less iron stores to compensate for the bleeding, if that makes sense. So all of these things, you can often find an example for one direction and then an example for the other direction. So it's really difficult to tease out kind of correlations and causality. So I don't know is the honest answer, but I suspect that you have a bit more of an autoimmune phenotype with hypothyroidism and ITP, and the hemochromatosis is just bad luck.
I think Alice has sort of tended to confirm the view that I get from other medics, that in fact there is no absolute clear and definitive position with regard to it.
No.
Hypothyroidism, I think, from what I gather and from my own experience, tends to suggest it's more linked to the genetic hemochromatosis than it is to ITP. But once again, I think there's a lot of research that needs to be done.
There are lots of different causes, so it depends.
I'm not sure about all of it.
Yeah, it depends what the cause is. If it's because there's iron buildup in the thyroid, then it's because of hemochromatosis. If it's because of antibodies attacking the thyroid, then it's an autoimmune disorder. So it kind of depends a little bit what the details are.
Thank you, Alice.
Hey, thank you, Colin. Right, Diane next, then Jim. Diane?
Yeah, I think one of the things we have to all be a bit careful about is not just taking supplements willy-nilly, because some of the supplements can have really adverse effects. Turmeric, for instance, we see lots about turmeric, but actually it can affect the blood. But the one thing that I've found is that there's quite a lot of robust evidence surrounding people that have got immune disorders having either an inability to absorb vitamin D, or their bodies are actually depleting the vitamin D that they do absorb. So for me, I've actually been taking vitamin D supplements, obviously, in collaboration with talks with my hematologist, and touch wood, that seems to be working for me.
We always check vitamin D and we always replace it low. And then I would generally say that everyone in this country, it probably needs replacement from about October to March.
Yeah, but to get the platelets up, I've had to increase the dose quite a bit more than perhaps you might read in a normal article, and there is research that supports all that, but you do have to be careful what you're doing, and you do need to do it. You
have to be careful with Thrombopertine and supplements, because it may affect
you. But you have to, for instance, I need to have regular calcium checks and D level checks as well. But I think it's quite an interesting route that some of the research is showing now, that perhaps there are these other things that we're missing, like ferritin and D levels and stuff like that. In the straightforward ITP cases, obviously, because you've referred to different deviations of it, which, this is the things Mervyn said earlier on, it just is so chaotic really in its behavior with everybody. You can be fine for several weeks and then suddenly you just bomb. Why? I think also stress plays a lot of input into how the ITP behaves. But I don't know if everybody else finds the same thing.
Yeah. Okay, thanks, Diane. Got a few more hands up. So Jim and then Bonnie. Jim?
Hi. So changing the subject a little bit, I'm wondering, I'm aware of all the tools in my toolbox and where I am at this point and what I'm taking, and it's starting not to work anymore. So I'm wondering, how do folks prioritize what they're going to try next. So to give you some background, first of all, I'm new to the group. My name is Jim, and I'm currently on Promacta. And I've tried in the past dexamethasone pulse and end plate, the romiplastin end plate worked for a short period of time to boost me enough to get a minor surgery done. And now I'm in sort of a stage where the Promacta is starting to I'm starting to fall below 30 and then fall below 25. So I kind of came up with a plan with my hematologist of what do I feel comfortable with, and then what do we try next. And I'm looking at what's on my list to try next, and I'm wondering, how do you decide which tool to pick next out of the toolbox and which to leave? You know, I've had this for a number of years, at least 15 years. I'm assuming I'm going to be living with this for the rest of my life, and I'm wondering, okay, if I haven't tried Rituximab or a splenectomy or this new drug that affects, this new pill that affects how your spleen possibly gets rid of your platelets, the fostamatinib or right. So I guess I'm wondering, how do you make that decision? I'm forced with this, okay, I'm falling below what I'm comfortable with, meaning I'm falling below 20, 25 on a regular basis. And I'm not exactly sure what to try next. And I'm finding it so stressful and not necessarily, because this is such a trial and error, I understand my hematologist is not going to say, let's do this. He gives me options. And it's very difficult to know, all right, if I'm going to deal with this long term, what should I try next? How do I prioritize what I'm going to leave for later in life? Does that make sense? And I guess that my question is out to the group, like, how do you help prioritize of the tools that you have, which you should go ahead and try next?
So can I ask, Jim, are you in America, the USA?
Yes.
Yeah, which parts?
Washington State, in the Seattle area.
Seattle. So you would you be going to the PDSA conference next month?
It's on my radar, but I'm not sure if I'm going to be in town.
Right. Okay. Because that would be the perfect place to actually ask the question, because you're going to have all of the experts there. And I know in the USA, it can be quite difficult because of the health insurance implications of, what the various companies can pay for as well.
Yes. No, I'm listening to the group, and I know there's a difference. Like, we would never be able to inject romiplastin at home, I don't think. It would have to be done in a hospital. So I know that there's many different hoops that we have to go through. So I know that my tools are maybe different than your tools in your toolbox left over. But I'm just finding myself struggling, like, oh gosh, what do I try next? I certainly, I know that there's things to consider, like, well, I want to be healthy enough to have a splenectomy if that's on the table. And certainly taking Rituximab during COVID was not the best idea, but it's not it doesn't sound appealing to me either way, whether we're in the thick of COVID or we're not, opening myself up to other opportunistic infections. So it's just, I'm struggling with how to prioritize.
Alice, any advice?
I think, everyone's different, but from a doctor's perspective, I would look at what suits a patient's lifestyle, what suits what they want. So if it's somebody that really doesn't want to come up to hospital very much, has a job that involves traveling or something like that, then Rituximab can be great because you have it, and then if it works, then you kind of don't need to see us as much for a bit. And then also side effects. So I think those are the main kind of pros and cons that I would write down for all the different things. And often people need a combination. So you know, it's not just has L-Trombopag worked, has Romiplostim worked. Okay, maybe neither of them worked, but if you added in Rituximab or if you added in mycophenolate, then maybe they will. Some, you know, it makes sense biologically, doesn't it, that even if you're making loads and loads of platelets but you're not stopping the destruction, for some people that's not going to be enough. So maybe you need immunosuppression plus a thrombopertine receptor agonist. I think in a way you probably have access to more drugs than we have here, which might make your shopping list longer. But I don't know whether there's there probably are cost implications as well. I think people did get very scared of Rituximab, but it's not been as bad as anybody thought it would be. The patients that have had problems with COVID are patients who've had on lots of immunosuppression for kidney transplants or something like that, who've not been able to clear COVID. But this was also much earlier on in the pandemic. So people now, we're giving it to and we're just making sure that they've had a good dose of a vaccination 3 weeks before, so that they're well protected and they've got those antibodies there, and then you give the Rituximab after that, if that makes sense. So I think probably we're beginning to feel like we need to start using it a bit more again, because there are some people that have just got into a real pickle, and you know that it may well just sort them out.
Right. No, and even if, you know, I'm interested in it because even if I'm a sort of a numbers guy, so I look at, okay, if this might correct the problem, even if that chance is, what is it? I've read it's 20% or even a little less than 20%. That's not bad, you know.
I think it's probably more than that. I think it's more like 60%. But I wouldn't go for a splenectomy before having Rituximab. You know, Rituximab wears off, and if it doesn't work, then you know, okay, there's a few things you need to be aware of, but it's not permanent. So I would definitely try that before a splenectomy.
Okay.
Thank you.
Okay, Jim.
Yes, thanks for your opinion.
No problem, mate. No problem. Bonnie, you got another question?
It wasn't a question, it was just a response to Diane and maybe to Jim. So Diane was talking about the kind of pros of doing vitamins and minerals and things like that, but I know, Alice, you mentioned also the kind of limitations of that, especially if you're on L-Trombopag. So I was on vitamin D, vitamin C, I took probiotics because my gut was crazy and everything was going quite well, and then my liver just went into total failure for a good kind of 3 or 4 months, and I came off everything. And basically it was sort of described as a perfect storm, because your liver actually kind of processes all these things. It's processing your L-Trombopag, it's processing all these vitamins and probiotics, and my liver just exploded. I came off everything, not my L-Trombopag, I reduced that slightly, and my liver, obviously, as we know, it regenerates, it sorted itself out. So I now only take a vitamin D children's spray, so I stay away from all tablets, because obviously you get the capsule there and you get all the different kind of additives, and I've gone into crazy pure person. So, you know, you can get the little baby sprays, like, so it's quite, and I just spray it in my tongue, and I take vitamin, so anything I take now is a drop under my tongue, and I don't take much, because, so I think you need to just prioritize what you're going to take, especially if you're on L-Trombopag, because your liver can really struggle. So it was only a word of warning if you take too much. So I just, every few months I was doing more research and adding another kind of like supplement into my diet, and I think everything worked really nicely, apart from my liver was the most unhappy thing kind of in the universe. The other thing I was just going to say, Jim, about if you haven't done Rituximab, I'm probably many people are on these Facebook groups, ITP Facebook groups, which I always think I should leave, because it makes me so anxious, because everyone's bleeding and everyone's putting photos of their bruises, and that really makes me panic. But there is a really good side to it, because people are chatting about stuff. But I would say anecdotally, the most people who talk about remission talk about it following Rituximab. Now that's anecdotal. It's absolutely not a numbers thing or a data thing. But when you read that, that's the sense I get, that when it works really blooming well. and they're out of remission, they're out of it for quite a while. I had it, it never worked for me. I went down when I had it. So it didn't work for me, but I would definitely agree, like splenectomy would be my absolute last resort, and probably wouldn't ever do it. Don't take a piece of me out. Bearing in mind that is actually, well, I don't know, something like 60% of your immune system being taken out. So I would say lots of people have had amazing success in rituximab. And where we are, I don't know where other people's hospitals, you tend to start on steroids, then go to rituximab, and then you go to the TPOs. So rituximab is generally earlier on in your ITP journey. So I would go for it.
The order just switched because of COVID.
Yes.
Yeah.
Yeah.
But that's what I was saying. I think we need to go back to using it.
Totally.
Yeah.
And it's not that horrific at all. I mean, you are chained to a kind of drip for like all day for 4 weeks in a row, but it's actually if it does it really well, it's like you say, over and done with in 4 weeks, and you have a really nice time for a while. But obviously it can also not work, but some people have had amazing success with that, and long-term success.
No, thanks, that's good to know. And here in the States, it is, I sort of finagled taking Promacta without having rituximab. Usually you have to have had that as a first-line treatment along with the steroids. And I'm not sure how I managed it, but I did. And sort of here, once you get an approval, you kind of hold on to it for dear life until they take it away from you.
The other thing I was going to say also, you can switch back to a drug that you've lost responsiveness to before and regain your responsiveness. Now, I did that I started on L-Tromopag and I was on it for 18 months, completely lost responsiveness to it, changed to N-plate, was on that for 2 years, totally lost the response to it, went back to L-Tromopag because of COVID, and I was about to start a clinical trial, but because of COVID, that knocked that on the head. So we all said, well, let's try L-Tromopag again. I'm still on it. Now, it's not doing amazing things for me, but it's keeping me at 30, 35. So it might be interesting, depending on how well you did on N-plate, whether you can go back to N-plate and give that a whirl before you do rituximab. I don't know how you feel about that, or what Alice maybe thinks about that.
Yeah, or the combination. So staying on whichever you're on and having the rituximab anyway. And then you may be able to come off, or you may carry on it.
No, that's a good point. And I would be, trying N-plate is a little bit more difficult because I have to go in for like an in-treatment IV push for that and stay there for a while. Not, it's a day thing, but it's still a little more involved. But it's good to know that I could go give that a try again, because it did get me up into the 60s at one point, which for me is very good.
Great stuff, great stuff. All right, any other questions, anyone?
Yeah, what's the consensus with everybody on what platelet count does everybody find their fatigue improves on? Because for me, I don't find that my fatigue really slows down until I get over 100. In fact, I've reached 117 recently, and that was, a revelation in terms of quality of life.
I've been quite lucky, Diane. I've never had any correlation between fatigue and platelet count.
Really?
No.
So
mine is above 50. I
feel
a different person, and above 100, I'm like swinging from the lampshades.
Yeah, ditto. Yeah.
Anyone
I don't think I had any correlation with fatigue either. But I didn't know that my platelet count was so low until it was. So even then I wasn't fatigued, but then they put me on so many steroids, I was swinging from the chandeliers. So, it was, I wasn't sleeping 50 minutes. I'd be lucky to sleep in a night. So yeah, I mean, it's different for everybody, isn't it? And it's different treatment plans and so on. And apologies for being so late. I'm afraid we got caught up with visitors.
Yeah, I can't stop sleeping. If my platelets go below 20, which they often do, I'm like sleep for like 12 hours straight every night.
Mm-hmm. Yeah, it's like everything though, isn't it? It's very, very individual. Some people don't experience fatigue and some have really difficult problems with fatigue. It really depends a lot. I think it depends a lot on your constitution and, you know, how the platelets affect your serotonin levels and various other things.
I know in various surveys, I think it's over 66% rings a bell of people have actually said they experience fatigue, and you know, when the platelets drop. So
we've done one at our hospital, and it's about a third.
Is it? Okay, yeah.
About a third of patients are tired, and the ones that are tired are very tired. So if they get it, I think if you're unlucky enough to be one of the people, it is quite noticeable. But equally, for some people, it's not a problem.
I think it also then links to mood as well. I know that there's something about platelets carrying serotonin around the body, so there's that as well. But I think if you're that fatigued and you just can't face anything, your mood dips as well. So I know that lower than 30, I just don't feel myself. I don't want to do anything. I'm really a different person. It really affects my kind of quality of life in such a big way. I don't really care about the bleeding. It doesn't really do. It's the fatigue and the mental health side of things that really catches me.
Yeah. One of the things that came up during our recent convention on day 2, we had a symposium on fatigue and anxiety, and the number of people who raised the issues around anxiety and mental well-being was huge. And it's a subject that I'm afraid in the UK is not being given the attention it deserves, really, especially.
I think the other problem is people don't even know what a platelet is, far less what I mean, I didn't really know. I thought I had a vague idea of what a platelet was before I did ITP, but it's really hard to relate to people. If you talk about cancer or depression or these things, people have got a level of understanding where you're coming from. You say ITP or blood disorder or whatever, they've got literally blank face, no idea, move on. So it's really hard to actually relate to people around you about what might be going on, because you look fine. Everyone always says to me, you look really well.
Yeah, but you don't look well if you show them the bruises.
Yeah, exactly.
I mean, this time of year, Bonnie, I don't like it because, I've just had a sort of bad spell. I've got some horrendous bruises. So I'm all covered up, and as a female, people don't realise that's got quite not that I want to go around bearing all.
It is cold in the UK in June.
Yeah, I know.
But people also make assumptions that you're kind of in a difficult relationship, or there's a lot of things that happen when you're with your partner and you are covered in bruises, and there's assumptions. They don't realise that there's a disorder out there, which means you look like this. So it's really difficult.
My ex-husband actually wouldn't go out with me when I had really bad bruising because he said too many people would come up to him and say, are you beating her up?
Awful.
Okay, we're coming up to the last couple of minutes. One last question. Has anyone got the last question before I round up? No? Right. We have got another one of these next week. We've got the Scotland meeting on the 15th. Of June with Dr. Catherine Baggett. So, you're welcome to join that. Just go to the website and register. We've got a few things coming up later in the year. We're currently working on the 2022 patient perception survey. So keep a lookout for that over the summer. That will be coming out. And also, we've got ITP Awareness Week at the end of September. And we're looking to make the September edition of the platelets a special edition with lots of patient stories. So if you've got a story of your ITP condition, how it's affected your life, etc., or any tips you've got, please write it down. We'll be happy to publish it in the September edition of the platelets. In addition, in Awareness Week, we are looking at doing another joint webinar with our colleagues down in Australia, the ITP Australia, and our colleagues in Jim's neck of the woods, the PDSA in the USA, with our friend Caroline over there. So that will probably be on the last Friday of Awareness Week. So there's loads going on during the summer, so please keep a look out on the website. that's about it, really. Any other questions? No? I'd like to thank you all for coming. Thank you, Alice, for jumping in.
Very welcome.
I hope you found it interesting.